Good afternoon, and thank you for joining us for today's webinar, Pathways to a Unified Healthcare Financing System in California, Key Considerations. My name is Tiffany Lopes, and I'm the Director of Communications and Publications at the UCLA Center for Health Policy Research. As a land-grant institution, we would like to begin by acknowledging the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is, the Los Angeles Basin and South Channel Islands. Next slide, please. If you would like a copy of today's slides, please email us at healthpolicy@ucla.edu. As always, this webinar is being recorded and will be posted to our website and YouTube channel in the coming weeks. Thank you once again for joining us today. And now I'd like to welcome Dr. Nadereh Pourat, Associate Center Director and Director of the Health Economics and Evaluation Research Program at the UCLA Center for Health Policy Research and a professor at the Fielding School of Public Health.
Thank you, Tiffany. Good afternoon, and thank you for joining us. Today, I and my colleague, Dr. Roby, will discuss the key design considerations for a unified financing approach in California. I would like to acknowledge all the report authors who will listed here and who will join us for the Q&A at the end of the presentation. I would also like to acknowledge the funding from California Health and Human Services Agency for this work. Next slide, please. The impetus for the report was SB 770. SB 770 directed California Health and Human Services Agency to develop a plan that is designed for achieving a healthcare delivery system in California that provides coverage and access through a unified healthcare financing system for all Californians, including, among other options, a single-payer financing system. The legislation has varying levels of specificity for key insurance features. It also allows for intermediaries to participate, but it does not specify type of organization, functions, or implementation. We followed the language of the bill closely and provided options when specificity was limited. Our work built on the report issued by Healthy California for All Commission in 2022. Next slide, please. Our goals were twofold. We conducted an in-depth examination of the context for implementation, the role of health plans, outpatient and institutional provider payments, equity in access and quality of care, and administrative burden on payers and providers. We conducted research of existing evidence for this report. Furthermore, the context for implementation and the chapter in the report on equity and access provided an examination of what factors prohibit or possibly promote access to and quality of care and could lead to inefficiencies and inequities under our current healthcare system and financing approach. The second part of this report focuses on key design considerations for what you see identified here, including unified financing models, eligibility and enrollment rules, the choice of organizations to perform administrative functions, covered package of benefits, use and extent of cost sharing, payment to providers and institutions, patient and provider choice, and promoting effectiveness, efficiency, and health equity. The bold text indicates what we are focusing on today because of time restrictions. Next slide, please. So first, we'll talk about the unified financing models that could be considered under unified financing in California. At one end of the spectrum is a single payer model where it's a government agency collects revenues and directly pays for services. Examples of this type of approach is available internationally in countries such as Canada, United Kingdom, Sweden, and also in the US, traditional Medicare fee-for-service is similar to that idea. On the other hand, under a multi-payer approach, government agency may still collect revenues and pay plans and specify rules for risk-bearing health plans that could participate under that model, but it could restrict or limit for-profit participation of for-profit plans. And then international examples of multi-payer systems are also available, as you see noted here. And in alternative option is a hybrid system where there's a combination of single and multi-payer options to provide choice of type of plans. There are no international examples, but in the US, the current systems under Medicare or the Medicaid programs are similar to this idea of a hybrid. Each option has different implications for administrative complexity and therefore potential for efficiency. Under the single payer, the possibility of achieving the lowest administrative complexity is greatest and more efficiency. Also, better access and equity and likely better impact on quality due to lack of administrative complexity. Under the multi-payer model, access can be promoted and equity can be promoted, but the evidence on impact on quality is more limited. And the hybrid models are most complex administratively because there are parallel payer systems. And the impact on access, equity, and quality, as we have observed to date, is quite variable, and it depends on the plan. Next slide, please. Looking at the key considerations under eligibility rules, I highlight two of those. One is who is eligible. Eligibility is going to be universal for all California residents, regardless of factors such as citizenship or other criteria that are currently used. Having universal eligibility is likely to eliminate inequities to access and quality of care because of the differences that currently exist in eligibility rules by type of payer, differences in lack of standardization of some benefits, and then choice of other types of insurance functions. Another important consideration is the criteria for residency and eligibility. For example, would anyone that moves to California would be immediately eligible versus have a lead time before eligibility is available. And these kinds of decisions clearly have impacts on the cost of unified financing. Next slide, please. The next set of considerations are focused on the benefits. Under SB 770, there are three specific features and objectives that are noted: a comprehensive package of medical, behavioral health, pharmaceutical, dental, and vision benefits, and particularly calling out primary, preventive, and well-care services. There's the option of providing a package of long-term care support and supports and services. And also there's another objective that services will not vary by age, employment status, disability status, income, immigration status, and other individual characteristics. So important considerations are to the degree to which benefits are standardized and whether or not a minimum package of benefits should be considered. They're currently, so these benefits could include medical, dental, and vision, as is specifically called out under the legislation, but currently the scope of dental and vision benefits is variable. So an important consideration is whether the scope needs to be expanded and whether it needs to be standardized for all the residents to promote access, equity, and quality. A second consideration around inclusion of long-term supports and services, particularly because these benefits have very significant cost implications, especially if they are provided universally and are standardized. However, it is also important to consider alignment of these benefits with federal and California requirements. And it is also important to consider what would be the financing mechanisms for the benefits that are currently not available consistently across payers. Next slide, please. Okay, I'm going to now turn it over to Dr. Roby.
Thank you, Dr. Pourat. So I'm going to cover a few of the issues around the cost of the system as well as payment. So first, I wanted to cover premiums and cost sharing. So SB 770 allows for both premiums and cost sharing. The idea being that you still need sources to fund the system that would exist, whether it be single payer, multi-payer, or some hybrid. Some of our funding, of course, in the healthcare system comes from tax dollars, payroll taxes, and also income tax, but also from premiums paid by employers and employees. SB 770 requires premiums not to exceed a certain percentage based on a progressive income schedule. And so if you were to move to a model with premiums, consumers would then have to still continue to pay premiums, whether in a single payer or multi-payer model, but it would be based on their income. In the same way, SB 770 provides some guidance on cost sharing, and we dealt with this issue around the impact of cost sharing, where we know that cost sharing can inhibit people's ability to use care, and applying cost sharing measures often results in unnecessary care being reduced at the same level as necessary care, as we find in the RAND health insurance experiment. And so SB 770 does say that essential services, including primary care, preventive care, and wellness care, should be without cost sharing, but it would have to be determined what other services would have cost sharing and what would not. We looked at the literature around deductibles and the style of cost sharing, and in most countries, the higher deductible plans that we often see in the U.S. are not allowed or not available, and so deductibles as a component of cost sharing would also have to be addressed. So both the source of funding in terms of premiums or tax dollars or fees would have to be addressed. In a single payer model, you can envision that could operate very much on a fixed premium based on income or a tax structure, whereas in the multi-payer system, there would have to be some level of oversight around people's payments via premiums, and a lot more regulation on the employer side about what is considered affordable and falls within the state mandated percent income based progressive premium structure. Next slide, please. So then I want to tackle professional provider payment. So we differentiated here in two different chapters around professional and what we typically see in the outpatient world as payment to physicians, separate from payment to facilities. So in terms of professional provider payment, we examine the different models of payment that are available currently. So you see fee for service, capitation, and also salary-based systems, whether somebody is an employee of a medical group or an employee of a large health plan that might be integrated and have salary-based compensation. So of course, there are different incentives that physicians and other professionals would abide by in terms of the services provided. SB 770 indicates that we should move away from risk-based payment. So it prohibits the use of capitation in a way that would intentionally reduce people's use of health services. However, there is some support for an idea where if we had a fee for service model, which I think would make sense, which we think would make sense in both a multi-payer or single payer system, that there could be certain types of providers that get additional compensation through separate payments. So, for example, primary care providers that provide this essential service around continuity may not be reimbursed at an appropriate level for the entire corpus of their services, and so a capitated model that would offer a base payment might be helpful in ensuring kind of operating revenue, and then there would be fee for service in addition to that that might be a smaller level that would compensate people for variable volumes within the practice. So even though SB 770 and a lot of single payer models out there seem to rely on fee-for-service systems, and it provides an ability for physicians to get paid for the volume they provide. It still incentivizes volume-based practice. And as we're moving away from volume into value-based services, some sort of hybrid of that might make sense. And it could very much depend on whether it's primary care, specialty care, or certain providers need to be compensated differently because of the way they practice, the level of consolidation in the system, et cetera. There are also countries that use risk, geography, specialty, level of training, et cetera, to compensate providers even in a fee-for-service system, where we could include adjustment factors to change the fee-for-service system. Of course, we have the Medicare fee schedule as kind of the gold standard of how to set fee-for-service reimbursement based on a relative value unit, and there's already an assigned value to that. However, there's this impediment that primary care and other less procedural specialties are often reimbursed less than their counterparts that do more procedures because of the way RVUs are calculated. And so there might be a need to reassess and kind of calibrate the reimbursement for specific providers given the context of the federal RVU system. So even if one were to use the Medicare fee schedule as a baseline and understand what the difference is between Medicaid, Medicare, commercial payment as a multiplier of the Medicare fee schedule, there might still be a need to kind of calibrate the RVU system to ensure that providers are being fairly compensated for the services delivered and remove some of those biases that we see in the current RVU system. We also have to consider the even whether it's a single payer or multi-payer model that physicians and other professionals practice in a context related to whether they're in a medical group, whether consolidation is occurring in their region, and so we might have additional needs to deal with there. There should also be a plan to minimize disruptions during the transition, where if you were moving to this fee schedule that was across all payers, that one would have to figure out a way to ensure that the fee schedule was improved for Medicare and Medicaid while also absorbing the additional cost of commercial fee schedule payments so that the all payer model is basically breaking even across all payers. And so you don't have the same price differentiation and discrimination that you might see in the current multi-payer model, whether it's single payer or multi-payer as the solution. Next slide, please. Then I wanted to focus a bit on institutional payment or facility payment. So this would include hospitals, but also ambulatory surgery centers, skilled nursing facilities, other places that bill on the facility side, usually through prospective payment using DRGs, APCs, or some other model. So there are, of course, differences in the current prospective payment system model used in Medicare and in a lot of commercial and Medicaid programs as well. But there's a lot of variation about how that works, across the states and across the nation, where there are some states that are still compensating Medicare or all payers in Maryland, for example, on a per diem basis, whereas California relies mostly on a DRG type of system. So we'd have to understand how those facility payment models need to be regulated and then built into a more cohesive single payer, multi-payer system. One of the ideas proposed not only in the Healthy California for All task force report, but also in SB 770 is this option for global budgeting. And so global budgeting can kind of have two forms. One, we see in European countries often where the entire system is based on global budget, and there's an overseer that's kind of making sure that growth occurs in certain areas and maintaining control over costs broadly. But there's also global budgeting that's occurring at the institution level in the states of Maryland, Pennsylvania, and others, and we've even tried it in California as well, where a hospital might have an all-payer global budget that's a blend of all of the reimbursement they would get for their historical claims, and it's built up out of either the DRG or per diem receipts that they've had in previous years, and then you attach a risk element to it so that there's a risk of payback or savings, and those savings could be used to reinvest in the system. In most states where that happens, professionals are carved out of that global budget arrangement. So the global budget would include inpatient and outpatient care, but would not include the professionals. So, for example, in the state of Maryland, which has their all-payer global budget model, professionals are carved out. There's a separate total cost of care initiative in the state of Maryland to control physician billing in Medicare, but they are carved out of the all-payer system, and really the all-payer system in that state focuses on inpatient and outpatient spending and is held to a certain standard in terms of cost growth over the years. And that is done prospectively. But there are also issues that would need to be dealt with in terms of when hospitals or facilities would get paid. So in Maryland, the payments are made basically on a claims basis, and then they kind of reconcile the budget with the claims paid. Whereas in Pennsylvania, it's done in a prepaid system where the hospitals are getting paid quarterly for what their budget should be, and they're able to use that money in a more flexible way to address needs that maybe fall outside of the billing system to invest in population health and that sort of thing. And so all of this, because it would touch on an all-payer type of system, would need to go through the appropriate waivers at the federal level to get them approved and ensure that the revenue that we rely on in the state coming from Medicare, Medicaid, health insurance, tax credits through the ACA are all being directed into the system to pay for it, but it needs to comply with federal law. And so there's authority that the Centers for Medicare and Medicaid Innovation has to grant 1115A and potentially 402 waivers. There's the Medicaid side, which has the 1115 and 1915B and C waivers. You also have the need to assess whether a 1332 ACA innovation waiver would be appropriate to ensure that those federal dollars are still flowing into the system. And it would require lots of negotiation with the federal government to do so. Next slide. And lastly, with a focus on promoting effectiveness and efficiency, there's still this need for care coordination and connectivity. One of the things that has made Maryland fairly successful in its all-payer waiver is the existence of their health information exchange and an all-payer claims database that allows not only for communication between provider to minimize inefficiencies. If somebody shows up in a different ER than they typically go to, they have an all-payer health information exchange that allows them to get clinical information, but also a state entity that sets rates and monitors the global budget or the cost limits that they're trying to abide by under their federal waiver. And so that capacity that would probably need to be developed across all payers. So of course we have the HCI medical claims database that's coming online now, but also a need for kind of a state health information exchange or a regional health information exchange that would allow that type of information to flow across. And of course, either in a single payer or multi-payer system where you have a lot more rate setting or price regulation, there could be administrative savings. As we see in the Healthy California for All report, there's a variety of administrative savings calculations. One of the largest ones that we see is around 8% for establishing a single payer program where you're equivalent to Canada, where you're saving a lot on the administrative billing denials overhead side. But if you had a model that's more multi-payer focused, of course, the administrative savings would be diminished in those sorts of situations. And so there are certain models where you actually save money because of administrative costs, as long as you maintain the same benefit level. But if you add certain benefits or reduce cost sharing or eliminate cost sharing, those costs can often overrun the administrative savings that you might have from changing our current system into a single payer or multi-payer system that's heavily regulated on the price side and on the business of delivering healthcare side. So I'll hand it back to Dr. Pourat. Thank you.
Thank you, Dr. Roby. So next, we are going to address another important objective of SB 770, which is promoting equity. And there are several considerations that we are going to discuss here. A lot of them have to do with how providers are paid, because there are a lot of inequities that are rooted in how providers actually are currently getting paid. And some of those are particularly relevant here. For example, if fee-for-service is the primary method of reimbursing providers for their services, it is important that the incentives of fee-for-service payment is addressed as evidence shows that fee-for-service typically promotes delivery of more services by providers. However, evidence also shows that it could lead to receipt of low-value care, and is not necessarily great for quality of care, even if it promotes access to services. Another important consideration is if provider payment rates are if the rates are set for provider payments, the uniformity is important for all providers so that the different providers, for different primary care providers, for example, or different specialist providers are all receiving a similar level of payment. So that also reduces incentives for some providers to behave differently. Another important consideration is even when you do uniform provider payments, you're promoting treatment of all patients the same. However, there are patients that have higher level of need, complexity, etc. And it is important, another important consideration is that you actually provide incentives for providers to take care of those patients and address their needs by doing different types of activities such as care coordination or managing the patient's care. And therefore, we present some evidence in the report that talks about the different forms of additional payments. We are calling it alternative payment models that provide specific incentives for providers to take care of all patients. Similar to payment to individual providers, incorporating equity in institutional payments matters. For example, institutions or hospitals that are providing care in rural areas have different limitations or issues, and it is important to consider how provider payments to institutions also promote equity. If an institution, for example, operates in an area with a higher higher level of individuals that are high need and high cost. Another important factor is that there are a lot of different features of insurance that determine access, determine quality, and determine equity. So a unified financing also needs to consider how to standardize all the other insurance features, such as, for example, utilization review and utilization management, and networks, and how networks are constructed, especially if there was a hybrid model or if it was a multi-payer approach rather than a single payer approach. And the last item is addressing social determinants of health. I think everybody has more and more, everyone is acknowledging that improving the population health is not solely dependent on this healthcare that's being received or provided, but other aspects of individuals' life are determining their health, for example, employment or poverty, etc. So addressing social determinants of health, whether it's got to do with how providers are being paid or other checks and balances that are incorporated under unified financing to make sure that population health is improved, which leads to equity, efficiency, and effectiveness. Next slide, please. So there are overarching considerations. We've talked about a lot of different features independently and individually. However, what is really important is considering the overall impact of all of these features that come together under unified financing and aligning them. If you're talking about reducing cost sharing, and if you're talking about maximizing or providing very comprehensive benefits and providing universal coverage, all of these features need to be aligned together to maximize effectiveness, efficiency, and equity. Another important consideration is that there is continuous monitoring and evaluation of the impact of unified financing. Once a program is developed, there is going to be refinements that are likely to be needed in order to make sure that everything works together. And if any issues arise, they are addressed. There's other contextual changes that do happen over time, such as changes in technology or changes in care delivery. And so continuous monitoring of aspects such as benefits are important. And last but not least, identifying the agency or agencies that would implement unified financing is really important, in addition to other factors that were discussed earlier, such as providing the data that's needed to make this approach work efficiently. Next slide, please. Okay, I will now hand it back to Tiffany to take us through question and answer. Thank you.
Thank you so much. At this point, I'd like to ask all of our panelists to please turn their videos on for the Q&A, and we can stop sharing the screen. Thank you so much. We've got some questions to get through. For folks who do want to ask questions, please use the Q&A function in Zoom. We will get to as many questions as we can. Thank you. Okay, first question. Dr. Roby, the report highlights the importance of federal waivers and points to Maryland's success in negotiating innovative arrangements with CMS. Given that SB 770 directs California to pursue discussions with the federal government, what is the realistic path forward for engaging federal officials today? Are there opportunities to begin building those relationships now, or does California need to wait for a more favorable federal administration before meaningful discussions can occur?
I mean, I can largely leave the political analysis to people smarter than me, often in the audience. I think currently it would be very challenging to negotiate an entire waiver package with the federal government that would achieve the proposal that is SB 770 and the considerations we developed in this report. That being said, there are ongoing negotiations around the Medicaid 1115 and 1915 waivers under the Callium framework. And so there is dialogue with the federal government. However, some of these reforms might be significant enough that it would be difficult to get done during this administration. I think some history is important here in that Maryland, if we look to them as a signal of like, how do you get an all-payer waiver? We have unified um, provider payments that are then built into every single payer. Um, it wasn't done through a simple Medicare or Medicaid waiver. It was done through legislation because when it was happening, the all payer program in Maryland already existed prior to the creation of DRGs and Medicare. And so there's a piece of legislation introduced by Barbara Mikulski that basically waived Maryland out of these requirements to institute prospective payment in Medicare. And so people call it the waiver, but it was actually like an explicit carve out of that state from the prospective payment model that Medicare was adopting in the early 80s. So California, I think, doesn't have the ability to get that done you know, in a Senate with a majority that is Republican. And So you end up having to navigate different waiver authorities um, through Medicare, Medicaid, and the ACA separately. There is an ability for California to enter into certain agreements with the federal government, specifically through CMMI and through CMS, where California could enter certain pilot or demonstration programs that are currently ongoing. And there might be an ability to get some ad hoc sort of global payment waiver, for example, that's attached to the CMS AHEAD model, which is a global payment demonstration that's going on now. That's within the ability of the state and the federal government to agree to. However, it wouldn't include the Medicaid side unless you also got an 1115 Medicaid demonstration waiver. It would not allow for the leverage of private insurance money in the individual market unless you were also able to get a 1332 ACA innovation waiver. And the budget neutrality requirements of all of those waivers are separate. So you can't use savings in one waiver to pay for surplus or losses in another waiver. So there is a I think there's a way forward with specific waivers that kind of could set the stage, but I don't know that an umbrella waiver at this time is really politically feasible. That being said, there are certain elements of um, a unified financing model, like provider rate setting, that don't necessarily require a waiver depending on where you set the rates, and have passed the test of federal lawsuits to ensure that they probably will not be subject to ERISA preemption. So there are some marginal steps one could take in that direction as well.
Thank you so much. Did the study address the differences between single payer for services and single provision of services, such as the British National Healthcare System?
Uh, yes, I'll handle this. I think this is a minor distinction. When we're talking about a single payer system, we're talking about generally government financing. And the question is it government financing of private providers of care, or are the providers of care and services public servants? And so I think that what we've done in the report is focused on public financing in alternative methods of public financing and unifying that financing, but not public ownership of the delivery of care or the delivery system.
Thank you so much, Dr. Kaminsky. What are the potential impacts on FQHCs?
Sure, so I can handle that. So I think one of the issues will be if there is a unified financing system in the state of California that changes provider rates, there are certain federal laws that can't be superseded, or there would need to be some sort of waiver. So um, right now, I would envision where FQHCs are protected by a PPS model where they're getting visit rates. Currently, Medicaid managed care plans are paying a certain level under capitation or other negotiated arrangements, and then the FQHCs are able to get a wraparound payment to compensate them for the full cost and make them whole in terms of the PPS rate. So that type of program could continue. Um, I don't think we envisioned that it would be possible to say, well, under this Medicare or Medicaid waiver, that the FQHC grants should go away because it doesn't, HRSA is not involved in this sort of reform. But certainly the payment issue would have to be worked out where a decision would have to be made either to carve out FQHCs and allow federal law related to PPS to continue, or ensure that FQHCs were getting their full visit rate, even though the rate setting fee schedule that might be adopted under a unified financing system would be subject to the same kind of reconciliation and wraparound payments that are being made now.
Thank you so much. In your assessment, do you think there's a current department, office, agency within California's executive branch that could handle this, even with staffing up, or would an entirely new entity have to be created?
I can start that and then others can chime in. I think a lot of it depends on exactly what approach California is going to take and how it all is going to come together. I don't believe there is a single agency that could do all of the different parts that are considered. And I'm going to just let others speak up about the different types of agencies. I think there, for example, provision of data is we currently have HCI, but there are we're talking about so they could play a role, but I think there's going to be a mix.
I'll just add, so I think as Dr. Pourat mentioned, I mean, you have to think about different agencies handle different things now, right? So our Medicaid eligibility much of it runs through counties, even though we have a somewhat unified system where people can enter through the no wrong door mentality, but they get filtered to different sources. And in order to continue leveraging federal dollars through Medicaid, Medicare, and ACA tax credits, you'd still need to do that eligibility check. And perhaps it still makes sense to have counties, an entity like Covered California, and the Medicare Social Security system administer those checks. But then the state would have to have an ability to funnel all that information into one source so that they know where to obtain federal financing for different elements and the paid claims that are happening. In addition, you have this need to establish the rate setting authority, make decisions about benefits. So a commission might be helpful in terms of deciding that on a yearly basis and making updates. And then, the administration would go through, the Health and Human Service Agency or another entity that would be set up. And as Dr. Perrott mentioned, like HCI has the ability to do claims process or claims analysis and administering oversight over spending, but they don't have the ability to do rate setting at this point. In the state of Maryland, they have the HSCRC, the Health Services Cost Review Commission, and they are doing all of that rate setting, and they have the all-payer claims database in-house and are able to work directly with hospitals on progress reports, understanding where they are on their budget, and making kind of marginal changes to ensure the system continues to work. So I think it would be a team effort, but we would have to do some sort of there would have to be an understanding of the roles that would have to be allocated to each agency, I think.
Thank you. Are there any sources of federal revenue that wouldn't be able to be preserved via federal waiver?
So I can handle that a little bit. So I think one issue here is half of our financing system is in California through the employer market is driven by foregone tax revenue, right? Where employers are providing health benefits to their employees. Those employees are not subject to income tax on the premium, on their premium contribution, and the employer is not subject to payroll tax on their employer contribution to the premium. And the state would have to figure out a way to potentially capture that money or leave it on the table and ensure that they aren't reliant on that source of revenue anymore. But I think any sort of system would have to try to ensure that those foregone federal tax revenues that are helping people in California are captured by this new system. And then I think there was another question kind of around like, are there specific elements that aren't subject to federal financing? So, for example, the undocumented expansion in Medicaid currently uses state funds, and that could continue in a unified financing model as well. But it would require us to understand what the costs would be for universally covering a population that is not federally matchable and ensuring that we had the revenue to pay for the services for all of those people. And that's also in the context of HR1 and the fact that some of those matching funds are going to be determined by whether the state is able to, audit work requirements and collect cost sharing from certain populations that wasn't an issue in Medicaid before.
If I could just add a little bit, there are also sources of federal spending on healthcare that come into California, they're not wrapped up in this at all, and that's the Veterans Health System, for instance, and the military coverage for both military people in the military and their families, also the Indian Health Service. These are all separate federal enterprises for which are not waivers and would not be included in the overall funding in California.
Thank you both. Dr. Pourat, how, I just lost the question. How would a unified system in which the feds are a major contributor handle federal exclusion of undocumented immigrants?
So I think Dr. Roby partially answered this question when he was talking about the sources of funding for individuals that are currently undocumented, obviously cannot receive any federal funding towards their coverage. And you'll know that in California, up to very recently, the undocumented, all the population of undocumented was eligible for Medi-Cal. However, the funds that went towards that coverage was state funds, state and local funds. So then I don't believe that that can be changed with waivers. I'm not the policy expert here. We have policy experts who could answer the question. So I'm expecting that if California opts for universal coverage for all residents, regardless of citizenship and immigration status, we still are looking at California sources for that, for those dollars.
Thank you. Did any of the policy experts here want to add anything to that, or should we move on to the next question? Okay. How might a single versus multi-payer model influence provider participation and potential decisions by providers to leave the state? Could providers elect to not participate and establish a boutique practice?
Thanks, Tiffany. I can respond to that a bit, and Jerry, also chime in, please, if you'd like to. In terms of single versus multi-payer approaches, I think that providers would have to weigh, the provider payment amounts as well as the administrative burden of participating in the separate system. So under a single payer approach, for example, the administrative costs that providers would face would expect to be much lower. And so even if potentially their overall payment rates for a given service are lower than what they would expect under today, they might still be willing to participate versus a multi-payer where there's a lot more administrative complexity and costs associated with that process. So, providers would have to weigh these different considerations for sure. Although in order to continue practicing in California, since, the vast majority would be participating in this unified financing system, you would assume that providers would continue to participate given that's where the patient population would be. Jerry, did you want to add anything as well?
No, I think that this is an excellent question, though, and we certainly internally had a lot of discussion about wanting to prevent payment reform from creating incentives for physicians or for any providers to not participate. And so, we currently experience sort of mixed participation already with physicians. We especially know this close to UCLA, where many physicians proudly say that they no longer accept any insurance. They're a cash-only provider of care, and that could very likely continue. I don't think we see forcing physicians to participate in the single payer or multi-payer system as a desirable outcome.
I just want to add one little thing here, which is, of course, the most undersupplied group of providers are in the primary care category, and they are the least well financed and compensated for their services. And one of the things that this system might well do, as Dylan talked about in combining capitation, maybe other kinds of investments as well as Delaware and other states have done, in addition to the fee for service for particular kinds of services provided, may create an opportunity to entice more primary care physicians into the state keep more into the state. And in addition, some studies of specialists have indicated in surveys of their interests and their particular tastes indicate that if primary care, providing primary care was a better compensated part of the medical system, they would have preferred to go into primary care rather than the specialty they did. So there are ways in which there may be some concerns about losing some kinds of specialists because of really bringing down the reimbursement rates with this new system, but there may also be real opportunities for emboldening and strengthening a very essential part of the healthcare system.
Add a little bit more on again, depending on where the state lands on different aspects of rate setting, provider payment, and incentivizing providers to provide care to everyone. Those are going to have significant impact on provider participation. A lot of the discrepancies that currently exist have to do with differential rate of participation by type of payer, for example, Medicare, private insurance, and Medicaid or Medi-Cal. So that's really important. So it could be the participation can be ensured if the rate of payment is considered better than what's currently available. There's also the question of concierge medicine. As Dr. Kaminsky mentioned, there are already providers that are outside the system, so to speak. And there are some providers that set themselves up as concierge medicine, though frequently a lot of those folks are focusing on very specific and limited scope of services. So in the long run, I don't think that the number of these type of providers has dramatically changed. There are always providers that are operating in that space.
Thank you so much to all of you for that lively discussion. This one's for Dr. Kariyala. On the efficiency side, would there need to be a need for pharmacy benefit managers in a unified financing model?
Thanks, Tiffany. In terms of PBMs and thinking about what PBMs do with respect to price negotiation and determining what drugs are covered and cost sharing across different tiers for different drugs, I would assume some form of that will have to continue into the future.
Thank you. What are potential impact on academic medical centers such as our own UC system?
Sure. So I can touch on that briefly, and then others can feel free to chime in. So I think if one were to establish some sort of unified financing model, where all enrollees could access a broad network of providers in a single payer style model or an all payer model, even if it was multi-payer, I think you would see potentially different enrollees accessing the UC system than do now, because currently the UC hospitals all have their own negotiations around managed care participation, et cetera. And so, in my experience in Maryland, where you have this all payer system, pretty much all of the large academic medical centers are in every insurance network. And where you see differentiation is on the professional side, where there's no all payer system for physicians. And so they make different decisions about which networks they want to practice in. But the hospitals are basically uniformly covered, and they are in every insurance network, and they're paid the same rate regardless of which insurance network you're enrolled in. And so that could ensure, that the UC system and the UC hospitals have a broad volume of patients, but also that a different set of people might have access to UC providers than in the past because of that set rate that the state would have negotiated. I think it's also important to note that, at least in the Maryland system and what we would envision for a multi-payer, all-payer type system in California, in Maryland, the different hospitals are not accepting a specific rate published by the state, as you might see in Medicare. They're negotiating with the HSCRC for their specific rate. So everybody who goes to their hospital generates the same level of reimbursement. But if you went to a different hospital across the street, the rate is different. So it's a hospital-based rate setting rather than a state-driven rate setting where the providers are taking a certain level because they decide to participate. The negotiated rate follows the hospital, but not the patient.
Thank you. I think Dr. Kaminsky took himself off mute. I'm not sure if you have anything to add to that.
Dylan made Dr. Roby made the point that I wanted to make about Maryland's system, that the rates are hospital specific. And I think that sends the signal that this unified financing system would be based on individual hospital experience, and not a single rate that is uniform across all hospitals.
Thank you, Dr. Kaminsky. We have time for one, maybe two more questions. Would benefits allowable under Medi-Cal managed care, but not Medi-Cal fee-for-service, like community supports and enhanced care management, become covered benefits for all beneficiaries?
This is the kind of question that gets at all the complexities of the U.S. healthcare system and all the different wrinkles. On the one hand, I think, first of all, as Dr. Pourat talked about, there's much greater recognition overall in the importance of all kinds of social determinants of health and non-medical needs that really address getting to promoting health status. And so that fits within that general domain. Moving in this direction would allow greater leverage to ensure those kinds of programs continue whatever the setting is. At the same time, as Dr. Roby pointed out, if we get waivers in California for Medi-Cal Medicaid funding, it's going to come with the proviso that we have to stay within the budget and orientation of what the federal government's established for the Medicaid program. How those all come together is going to be hard to sort out, but certainly part of the issue will be what are the fundamental underlying required benefits to be covered under the unified financing system.
I'll add a little bit to that. These benefits are designed for subgroups of Medicaid currently who you could define as high cost, high need. These are individuals that have a pretty complex profile, not because they have multiple medical conditions, but their care is also complicated by experiences of homelessness or severe mental illness or substance use disorders. So the reasons these services are being provided in California, they are provided under waivers, by the way. They are not part of the required Medi-Cal benefits at this point, but they are provided because of the acknowledgement that a lot of these individuals have a lot of challenges getting the right kind of care that they need. And a lot of those services are not really covered as standard benefits. So they are important. They are not necessarily going to be important for every single individual, but the reason they're there is that they're considered to address some really important social determinants and other factors that will make a difference in the actual outcomes of care and have implications for efficiency.
Thank you so much. That is all the time we have for questions. I just want to once again thank all of the panelists and speakers today. If folks would like a copy of the slides or link to the recording, I'm going to post our email address in the chat. Thank you so much once again for attending, and have a wonderful rest of the day.